Hi all, I'm Dr. Malathi working as a professor in Triple M College of Nursing. So in this video, I'm going to discuss about the mechanism of labor ROP, which is nothing but right occipital posterior position. So it is going to be a demonstration procedure for BSc nursing student, post basic and also for MSc nursing students. The objectives are introduction, definition, principles, characteristics, movements, summary and conclusion. Introduction. ROP position is a common malposition of the fetal head during labor in which the occiput of the fetus is directed towards the mother's right posterior quadrant of the pelvis. So in this position, the fetal head enters the pelvis in the incomplete flexion. Leads to longer and more difficult labor. So understanding the mechanism of labor for right occipito-posterior, it is important. The mechanism of labor will influences the descent, rotation and mode of delivery and also helps the nurse and obstetric team to anticipate the complications and we can plan appropriate management. Coming on to the mechanism of labor definition, as the fetus descent, soft tissue and bony structure exerts pressure which leads to descent through the birth canal by a series of movements. Next is principle. There are three principles. Descent takes place throughout the labor is the first principle. Second is whichever part leads and first meets the resistance of the pelvic floor will rotate forward until it comes under the symphysis pubis. Whatever emerges from the pelvis will pivot around the pubic bone is the third principle. So as I told you earlier, all these definition as well as the principle is common for all the mechanism of labor. Characteristics. So there are six main characteristics for ROP. The lie is longitudinal, presentation is cephalic or vertex presentation. The position is right occipito-posterior. Attitude is head is deflexed. Denominator is occiput. Presenting part is the middle or anterior area of the left parietal bone. Here in the right occipito-posterior position, the occipitofrontal diameter, that is 11.5 centimeter, lies in the right oblique diameter of the pelvic rim. So occiput touches the right side of the sacroiliac joint and sinciput faces the left side of the iliopectineal eminence. Movements. First is flexion. Flexion, descent takes place with increased flexion and occiput becomes the leading part. So what happens here is due to the contraction and retraction of the uterine muscle, the pressure will be more forcibly exerted through the fetal spine to the occiput than the sinciput. Next movement is internal rotation of head. So occiput reaches the pelvic floor. So here usually the occiput turns 3 by 8 of the circle followed by shoulder rotates 2 by 8 of the circle and the occiput will comes under the symphysis pubis. Shoulder will reach in the right oblique diameter. Crowning. So once the occiput reaches the symphysis pubis, the occiput will get impinges beneath the subpubic arch and the head is crowned. Next movement is extension, that is the head. Sinciput, face and chin sweeps the perineum and the head is borne by the movement of extension. Next movement is restitution. Occiput turns 1 by 8 of the circle towards the right side and the head realigns itself with the shoulder. Next movement is internal rotation of the shoulder. Shoulder enters the pelvis in the right oblique diameter. The anterior shoulder reaches the pelvic floor first and it rotates forward 1 by 8 of the circle to lie under the symphysis pubis. External rotation of the head. So at the time of internal rotation of the shoulder, the occiput also rotates 1 by 8 of the circle towards the right side. Next, last movement is lateral flexion. Anterior shoulder escapes under the symphysis pubis. Posterior shoulder sweeps the perineum and the whole body is borne by the movement of lateral flexion. Coming on to the summary, right occipito-posterior position is a frequent malposition of the fetal head in labor where the occiput lies in the right posterior quadrant of the maternal pelvis. The fetal head usually enters the pelvis with deficient flexion, resulting in slow descent and delayed internal rotation. During labor, the head may rotate anteriorly to the occipito-anterior position and rotate posteriorly or remain persistent occipito-posterior position, leading to prolonged and painful labor, especially in the second stage. So, the mechanism of labor in ROP is therefore often inefficient and may require close monitoring and obstetric intervention. Conclusion. ROP position significantly affects the normal mechanism of labor by altering the process of flexion, rotation and descent. Although many cases correct spontaneously to an occipito-anterior position, persistent ROP can result in prolonged labor, maternal exhaustion and increased operative delivery rates. So, early recognition, continuous assessment and timely management are essential to ensure the safe maternal and fetal outcomes. Understanding the mechanism of labor in ROP, it helps the nurses and clinicians to provide the effective care and prevent the complications. Thank you.